Welcome back to another episode. Today we are talking to Rose Griffin, who is an SLP, speech and language pathologist, as well as a board certified behavior analyst. She's a good friend of mine for years now. And today we are talking all about first words when babies start to babble and then it progresses to first words, and what to do specifically if first words are not clear, if they are having articulation errors. It's a great episode. Hope you love it. Let's get to this episode with Rose Griffin. Okay, well, welcome to the show again. This is like your third or fourth time, I think, Rose.
It is. I'm excited to be here.
Yeah, so Rose and I, as I said in the intro, go way back to, almost 8 or 10 years ago when we first connected, and we remain good friends and colleagues. And yeah, so I thought I would have Rose on. She has such a great background as both an SLP for many, many years, decades, and then a BCBA as well for many years. Great combo. I've had other what they like to call themselves unicorns. I don't know if you like to call yourself a unicorn, but that's a combination of a BCBA and SLP. You go by unicorn, Rose?
I do. I love it. Yes, this is my nerd herd. I think maybe Tamara Casper came up with that, maybe. But she uses that one online. And yeah, I love to be in the company of those people. I remember seeing Tamara Casper speak when I was down in Austin. And I was just amazed at how smart she was. And now she's really like a colleague and a friend of mine. She's been on my podcast. I know she's been on yours.
Yeah.
So it's just great company to be in. And I'm really proud. There's less than 600 of us worldwide now when this will come out. But every week there's new ones cropping up. So it's a really nice group of people.
Yep. Okay, so I wanted to have you on, and we can link some of the other BCBA SLPs when they've been on the podcast, including Tamara Casper and Barbesh and others that we've talked about, similar issues. Like I know Tamara, we talked about apraxia, and that is a really hot topic with, well, they physically are having a problem producing speech. But I think there's a whole lot of confusion in the autism world and in the world of speech delays, because
Mhm.
as you know, I changed my podcast name to Autism and Speech Delays Made Easy.
Yes.
Um, because really the first sign of autism in many kids is a speech delay. And but just because you have a speech delay doesn't mean it's autism. And these techniques really work for both, as I'm sure you know over the years. But a lot of confusion about, what is typical development? When do P's and B's and M's come out? And should we be working on vowels or consonants? Should we be focusing on, phrases or one syllable words and all that kind of stuff? So I thought we would talk about like typical baby development, infant, toddler talking. We're not going to cover receptive abilities or imitation. And we know all of these things are super important social skills. We've had, people on about joint attention and those sorts of things. I mean, we might get into a little bit of that. And then when there are really articulation errors and what to do about that for both parents and non-SLP professionals. So we're not going to get into your background because you've been on the show numerous times,
Yes.
and we can link those other shows in the. I think you were definitely on podcast number 10
Oh, wow.
many years ago,
Yay.
and
Yes.
we're going to link that in the show notes because it is still a very very much a favorite. Um, so let's talk about infants like under 6 months. Like, what should they be saying in terms of sounds?
Right. I mean, I think when kids are, I'm a mother of three too, as well. So, and my kids are typical language learners. I always let everybody know that. I think what's amazing when kids are just starting to develop, you can see one of the biggest things is they are going to start to develop, like we talked about, joint attention, that social engagement, where they are going to start imitating some sounds. They're going to start to babble, and that's going to be really exciting. I think that's something that people realize if usually there's just just a very rough marker of by the time a kid is one, they're going to have their first word. Jimmy Fallon has that book, I think is Dada or something like that. My husband has that book. I think my mother-in-law got it for him. Because that's kind of that marker where I think sometimes parents, if they're not in the field and doing what we do, if a child is not yet speaking by that age, they're starting to think like, uh-oh, like my child should be saying some things. They're not. They're getting upset. They're not getting their wants and needs met. And the CDC just came out with pretty recently some new guidelines, which I know ruffled a lot of feathers as far as like, are these appropriate? Is this right? Should we not be worried? Well, my pediatrician said, don't worry about development because your Uncle John didn't start talking till he was 5. And I know that these sound silly, but these are the recommendations I know that people reach out to you about and me too, like this wait and see. But we know that's not the case. And specifically with speech sounds, there has been some really good research that has come out about, well, when do these sounds typically occur? So, like, as a really easy example, a student is going to usually be able to say like a P sound, a B before something that's more complicated like R or TH. And what's really interesting to think about is the other sounds that are around those specific words are going to be hard. So for you to say baba might be easier because the vowels are the same. And the B is an easier, earlier developmentally appropriate sound. And or for you to say the word bar or back, that's going to be harder because of the sounds that are around that. And I think that parents and a lot of clinicians, if they haven't taken all the coursework that speech language pathologists do about speech sound development, we take a lot of coursework about, well, how is the sound particularly made? What does research say? When is it made? And then we do a lot of listening to kids and saying, like, well, wow, you know what? They're always taking off the final consonant of a sound. Now, sometimes there's processes we call that are typical, like a final consonant deletion. I wouldn't expect somebody really young to be able to include the final consonant, like back or bag. At some point, it's typical for them to do that. But once they reach a certain age, we would expect they're going to include that final consonant. So speech therapists do a lot of like listening and taking samples down, notes, and then analyzing, well, what sounds is a student having trouble with? Or is there a process that's occurring that shouldn't be occurring anymore because of the student's age? So I do a lot of consulting and sometimes with parents that live internationally that maybe don't have a speech language pathologist. Sometimes they heard me on your podcast, Mary. So thanks for that. And so I try to frame it of let's see what sounds are in a child's sound inventory. So what sounds can a student say either spontaneously or are they stimulable for? So that's a word that we talk about a lot in the speech therapy word, meaning if you're having trouble, Mary, with the K sound, but if I just kind of probe it and say like, okay, we're going to say a sound, I'm going to say it, then you say it. And then you're able to say it in isolation and maybe at the end of a word, but you're having trouble maybe at the beginning and the middle, then that lets me know where are we going to start our intervention? Well, Mary can say it in isolation and she can say that sound at the end, but she can't say it at the beginning of words or in the middle. So now I have a clearer picture. I've analyzed what sounds are in your sound inventory, what sounds are you stimulable, can you say, and then where do I want to start my intervention, which we know as behavior analysts, we like some behavioral momentum. So of course, we're going to start with isolation and we're going to start with where you already can say it. And then we're going to embed some of those words where it's more difficult. And then that's kind of where the therapy magic all kind of takes place.
Okay, so that was a lot. So babies,
Yes,
they begin babbling these baba, dad,
right,
mama.
right.
6 months, 3 months, 4 months.
That's a good question. Yes, it happens pretty early. All that type of babbling is going to happen. And then you start to get into different types of babbles until we get into the real
Yeah,
word. So you can kind of see that systematic progression where it starts off easier and then it's going to get more complicated until
yeah,
students are saying that single word. Yeah.
yeah. And, I think a lot of the parents that are course participants in my world, and I'm sure in your world as well, regardless of age, their children are, say they're 2 or 3
Yeah.
or
Right.
4, but they're considered nonverbal or non-vocal. And when you know, you said a sound inventory, like in my world, in my course, we teach parents how to do a language sample where we set a
Right.
timer, we have them listen, and I know the speech pathologists are 1,000% better at listening for sounds and like, hearing garble and being like, okay, he's missing this sound or that sound, or he has this deletion or that deletion or the schwa ending. And I'm like,
Right.
so I just kind of go with a non-SLP approach of, set a timer, listen for words, and if he's reaching for a bottle and saying Baba, or
Right.
he's saying Baba when he sees a sheep, or he's saying Mama as he's, reaching his arms up to be held, then that's great too. That's great information to write on your language sample. So it's not just about like what sounds are he making, which is part of it,
Right.
but is it coinciding with something he's looking at or wanting? And then,
Absolutely. And I think that's
then that
important
gives
to,
a
yeah,
good,
to write those words out, especially when a student, if I'm seeing a client and they are new to talking, I might just take a 10-minute period of our sessions where maybe I'm working on joint attention or in a more structured way, but then we have a time where they're spontaneously communicating. I'm going to write down those exact words that I hear in the session so that I have that running log. And then I'll also talk to parents and say, just keep a running log. If your child is new to speaking, like I would love to know, what are they spontaneously saying? What are they spontaneously communicating? And obviously, we know that we are wanting to get something like you say, Baba, like maybe we want the bottle. We're going to say those words because we're using our communication to navigate our environment and get our wants and needs made. So I think that's really important that they obviously have a function for the student, that we're not having learners, say, and we haven't got into really intervention, but we want to make sure that we're extremely cognizant if we're working on a coax or verbal imitation training that those words are powerful for the student and they really have meaning. That's really, really going to be most important for our learners.
yeah. Yeah. So, and I think that's super important. And I think it's really good to empower parents who are with the child all the time to be listening for words, word approximations, or even just sounds, because
Mhm.
I've seen many, many children being labeled nonverbal, which newborn infants, when they come out of the womb, are already verbal because they're crying for bottles, they're crying to be fed, they're
Right.
crying to get diapers changed, so we are in essence all verbal beings. That's just their verbal behavior looks different. And as kids get older, they stop crying and they start talking. But for our kids, that transition isn't always smooth. So I do have an assessment, a digital assessment that is part language and learning skills that people can do, and also get scores in self-care and problem behaviors. And that's a good start. The language sample is a good start. I also have this thing that I developed many years ago, like probably 2 decades ago. It's in my first book, The Verbal Behavior Approach, where I have parents, when we're talking about articulation, write down clear words
Yeah.
versus words that are mushy, like they're
Mhm.
deletion on the end or whatever. And this
Mhm.
all stemmed from a classroom I went into, and they were practicing labeling, tacting,
Huh.
and with one syllable words, the kid was fine. He was probably 8 or 10 or whatever age he was. And he was like car, truck. But then when it was like bulldozer, it was like blah, blah, blah.
Right.
And practicing errors doesn't make sense, right?
That is it. Well, that's an amazing point because in some of the consults that I do, teams, clinical teams where I consult, and also parents will say they're confused. Like, should that count as correct? And that's a lot to tease out. Number one, antecedently, if a student's having trouble with more than one syllable words, we wouldn't pick bulldozer unless that's really his favorite. And maybe he's supplementing with an AAC device or something like that. But is that an appropriate target just anyway for a coax? Probably not, right?
Or a
Because that is a
known
good,
skill. Like they have
Right.
that in the known box, but it's like then you're practicing errors. And
Right.
so yeah, and breaking things down, and this is really I learned years ago from Barbesh is instead of doing like a goal in the IEP for Johnny to say 4-word utterances, let's go with one syllable because a
Right.
word can be cat, which is one syllable, or refrigerator is
Right.
one word, but 5 syllables. So
Hmm.
bulldozer is 3 syllables. And
Right.
so we have a free syllable sheet that a speech pathologist took the work of Barbesh and made it into functional sounds for 1 syllable, 2 syllable,
Yes.
like, and I know you have tools like that. You actually created it
Hmm.
for this podcast, right?
Yes. Well, we have a free speech and language milestones course that gives you information about more specific
Yeah,
milestones that we don't have time exactly to talk about today. And so I
right.
will
But
share a
we'll link
link.
that. Yeah,
Yeah,
we'll link that in the
absolutely.
show notes right
Okay,
below
great.
the podcast. So, I mean, you and I, Rose, I think are very practical in terms of trying to get people to realize that practicing bulldozer, you know, isn't in the student's best interest. And there are some weird things like I had a client, Chino, which I show videos of Chino at permission. Chino's probably in high school for now. It's been so many years. But he could say no. That was a number one word, clear word. And he could say Cheeto,
Oh,
which was a clear word, but his chino was a number two word. It was not clear. So
right.
he physically could do it. So it was just like you were saying earlier, it was just a matter of prompting, slowing things down, chino,
Hmm.
and then putting it back together. And that was able to. So for some kids, getting unclear words clear with the
Hmm.
help of a speech pathologist or just with the help of these
Right.
prompting procedures, um, can really make the difference. But for some kids, they remain stuck at
Yes.
being essentially, you know, um, nonverbal or non-vocal or very limited. So what are some things to consider interventions for essentially
Yeah.
kid and like I have had people on the show, speech pathologists on AAC and stuff. We're not going to talk about that in this. I mean, not that you can't mention that, but like I don't. We're talking about trying to get vocal.
Yes. Oh, yeah,
That's
absolutely.
really my goal.
I think if you have a speech language pathologist, I think talking to them about how does verbal imitation or a coex, whatever you're calling it, work into your child's intervention plan. Because I know some speech language pathologists might be overwhelmed with maybe some of the language things that we're trying to like, let's just get your child speaking more. Let's increase their MLU. Let's increase their spontaneous language. And so that may not be something that's a priority in their mind clinically. But if it's a priority for you and your child, because I know all parents want to hear their child speak, they want them to have a way to communicate with the world, is what I always say. Help me find my voice, right? And I think that's important. So you might have to advocate for it. And we want to make sure that we don't want to turn kids off to speaking. We don't want to, let's say that Mary's working on K in speech therapy with Rose, with the speech therapist, but K is new for Mary. So we don't expect Mary to walk out of the therapy session and say that K sound perfectly. So we really want to be cognizant of just allowing the student to say the word, how they are. And then the last part of therapy is going to be to generalize it. We know we always want to plan for generalization. So that means just having a good ongoing communication with your speech therapist that is there with you locally, that you're working with, because the last place is going to be that spontaneous language. Like you might be in the therapy room, you can say it in all positions of words, you're starting to say it in sentences, but when you go out and you're playing or you're saying something from a show or something, you may still have that speech sound error because that last piece where we're going to generalize that specific speech sound is going to be to the natural environment. So I think that's something to think about because we never want to turn kids off to verbally speaking. We don't want it to be too much response effort. That's something to think about. The other thing that I love to do I've done this in a public school and a clinic, is as a speech language pathologist, if you have one available, I would give, or, the ESA is part of the VB map. I know you talk about that in your courses that Barbara Esch created. So giving something like that where you can see the sound inventory, picking words that are functional targets. Let's say there is a speech therapist on the team. They work on those new words in therapy. And then once they've met a criterion, then they're passed on to the team to be worked in a maintenance. So let's say the student gets speech therapy once a week and they've mastered 5 to 10 words. Well, then those 5 to 10 words or picture cards will go into a maintenance folder. And then other staff members, registered behavioral technicians, parents, caregivers, then work on those words in maintenance to keep them in the child's repertoire. So I think that's really important to think of it holistically. And how can we pick words that are functional and then generalize them to natural environment teaching? So it's not just at the table, that it's really words that the student is going to use spontaneously in their environment is really, really important. And the only other thing I wanted to share is I could share a link with you. I've been doing this little series on Instagram with speech therapy hacks, but the one resource is from a research article that says, at what age should a child acquire different speech sounds? So, of course, we're going to acquire P, B, M, H, some of those things earlier, then F, then L, then CH, then R. And so it has a really nice tree kind of visual with the different ages. So I'll share that link for you too, Mary. And I think that it makes everything really easy to understand what we should expect to hear from students as far as their sound inventory.
Yeah, that sounds good. Um, I think a couple things that as you were talking, I was thinking to add is make sure, like just like that student that couldn't say bulldozer well, make sure that all of your knowns, all of your targets that the child is verbally trying to say are relatively clear, because we don't want to keep practicing errors. And so if a child can say mama, but you eventually want them to say mommy, start where the child's at, mama.
Mhm.
And then you'll be able to, eventually get echoic control, which doesn't happen. I mean, it can happen really quickly, even under the age of 1. Child can start echoing baba, versus dada versus mama. For some kids, even typically developing kids, like I know Everett, who is Rachel's son, who I feature, who's on actually my podcast cover photo. He had a speech delay, pretty significant speech delay, but it was during COVID. So he never was actually diagnosed or treated.
Mm-hmm.
Mom just used my course, but he didn't have echoic control until like 25 months. And then
Mm.
looking back at even my typically developing son, Spencer, who just became a physician recently, he oh, well, I didn't know anything about anything back then because both, Lucas was diagnosed and Spencer, it was even before Lucas's diagnosis. But looking back on his baby book, he was like over 2
Mm.
when I got echoic control. But I didn't know what echoic control means. I say train, you say train.
Right.
Um, and the reason I know that from his baby book is my husband took Spencer down to Florida to visit his grandparents because I wanted to wean him from breastfeeding, and he was over 2 and I was losing my mind.
Right.
And um, he flew down, and they said he was really into Thomas trains, and he had 4 or 5 of them. And the grandparents said, any train that you say the name of, we will buy you. And so he went down with 5 trains, came home with 17 trains. And I
Oh
got
my
that in his
gosh.
baby book.
Oh my gosh.
And I mean, I don't know. I mean, this isn't obviously research. I
Yeah.
don't know when he got it, but some kids, even kids that go on to be typically developing are delayed with echoics for whatever reason. So using the techniques like in my early learner materials, like the shoebox, saying the word 3 times, it, if they want the thing to put it in, then it's part manned, part request.
Mm-hmm.
So gone are the days where I would recommend sitting across from a child who is not fluently echoic and saying, say car, say
Yeah.
ba.
No.
You have to go in the back door. You have
Right.
to use playful techniques, and you have to include the activities that have manding, like bubbles and
Hmm.
those kind of things, to try to elicit some degree of echoics, wouldn't you say?
Yeah. Oh, absolutely. And I talk a lot about now the power of joint attention. This is my course that I've been talking about a lot, but we have to have that social engagement. So it is a really fine line of if your child has issues with their speech clarity or people are having trouble understanding them, analyzing what might be helpful for them. But we never want our programming or therapy to turn a child off to verbally talking if they are, because that is a very fine line. So we always need to be analyzing that. And just an aside, too, for parents who might have a child who is school age, you know, there's a difference between a medical model and a school-based model as far as speech therapy services. So let's say that, you have autism, but you're in all general education classes. Maybe you're getting some speech therapy for social skills, but you have trouble with R. Okay, let's say you have trouble with R. Well, that doesn't necessarily mean that you're going to get a speech therapy goal for that speech sound. Because if it doesn't have an adverse impact on your educational performance, every school is going to interpret that line there of the law a little bit differently. So I would just say if it's important to you, if it's bothering your child about how they're saying certain speech sounds, it doesn't mean that they're automatically going to get picked up for speech therapy services because of that. So that is something to think about if you have a child who's conversational and you think, oh, if it was a problem, they would alert us at school. That's really not the case. So every district is very, very different. I work 2 days a week in my kids' own school, which has been really fun for me as a mom. And I serve some students have autism, but I serve other students who are working on speech sounds. We have a really nice system. Other school districts may say, no, that's not an educational need, and you need private speech therapy. So just something to think about, because I know you have parents from all different, levels that are listening to your podcast. So it's not the case that if it's a problem, somebody may say something to you. It may be a problem, but it might be a problem that needs to be handled differently, or it might need to be a problem that you bring up to your team. So it's something to think about.
Yeah, and especially I have friends with typically developing kids or kids with autism or signs of autism who get to be 3 and 4 and fully conversational and falling apart with R's and L's and
Right.
TH's,
Mm-hmm.
um and I've seen some of them let it go, waiting for somebody to sound the alarm.
Mm-mm.
And and getting private speech therapy for something like that, for articulation, isn't going to be a walk in the park either, because there's long waiting lists and private pay situations. And
Mm-hmm.
so what age so I would advise people to not wait if your child's not babbling, not wait if your child's not saying a couple words by one, not waiting if your child's not putting words
Right.
together by two. Like, we have to act, and it's better to be acting and everything works out fine. But I also think by like 4, if their articulation
Mhm.
is garbled, I mean, would you say, I mean, am I overreacting?
No, you're not overreacting. And that research says, by 5, a student should have almost all their sounds. And then R comes in, TH, and at 6, it's pretty much you should have all your sounds. Now, everybody's going to have a different opinion on that clinically and when is it appropriate to work on. I think the other thing to empower parents is if you find somebody, now it is a financial issue, but if you are concerned about your child's speech clarity, how they're making their speech sounds, you can contact somebody who is a private paid speech therapist and say, I really want to work on this. This is important for me. Can we do this evaluation? Obviously, it's going to be more expensive that way, but I think sometimes parents think like, oh, well, I have to have this concern or it has to be some major issue to contact somebody, but it doesn't. It doesn't. Okay. So you really have that right as a parent, if we're not talking about school, if we're just talking about private providers. And obviously, providers that take insurance are going to have wait lists. And depending on your area, it might be hard. But there is teletherapy too. That is an option that speech therapists provide teletherapy here in the States and abroad as well. So that is a really nice option for parents as well, and is very backed by evidence and is a very nice way to help people.
Yes. And the other thing, and I know we're kind of running out of time here, but the other thing is having a speech pathologist on the team or available who isn't up to speed with the dynamics of verbal behavior, the importance of the man frame, the importance of length of utterance being syllable sounds, and adding carrier phrases. I did a whole blog on that, to avoiding carrier phrases,
Yeah.
because you have a child that's barely saying pretzel, pretzel, and then you add I want pretzel, and then it's I want blah,
Right. Yes.
blah. And
Hard.
you know, so yes, and if you can get a speech pathologist like Rose, that's great.
Yeah.
And if you can afford private pay and have somebody, but there are also many techniques you can use as part of my course. I know Rose has courses that break things down for people, for lay people, and professionals who are not, speech and language pathologists, to work on like common sense ways
Hmm.
to improve language throughout the day, with or without an expert speech pathologist too.
Absolutely, because I think what I've learned so much from being just in your world and being friends with you is there are a lot of people who just don't have access to qualified professionals, like the boots on the ground, as you say, team. Sometimes that's hard depending on your location, whether you're abroad or you're here and you're somewhere rural and there's a wait list. Like I've talked to people who are BCBAs who are like, I think I'm just going to become a speech therapist because we only have one clinic and there's wait lists, like a year. And we know that that's not best. We just know that's not best. So teletherapy is a nice option. You just kind of have to do some digging on your end as far as finding those people. I'm licensed in Ohio and Washington State and provide parent coaching and things like that and coaching to clinical teams. Because I too, from a clinical perspective, thought that every ABA center should have a speech therapist at least on hand. But that's not always the case too. And so that ebbs and flows. I know that a lot of them would really benefit from that and want that information too. So we provide help, that way in form of consults because it is important and you need to get started soon.
Yes. Okay.
Yes, yes, soon.
Get started as soon as possible. And
Yes,
there's a
absolutely.
lot you could do from infancy in order to expand your joint attention, expand babbling, listen for sounds, um, focus on the right things in the right order. And when you have local professionals, even if they're not initially on board, you might find that you can get them on board relatively quickly. So I think that's a good way to wrap this up, Rose. So helpful as usual. We'll have the show notes. We'll have the links that Rose talked about, and we'll have some other links there. So, like it's just making progress, and
Mhm.
each child find your baseline, get your language samples, do my digital assessment pre and post. I mean, we're really seeing some really nice gains across the board with the pre and post digital assessments that tens of thousands of people have taken. So we can link that in the show notes as well. So thank you so much for your resources, and we'll be chatting again soon. I'm sure this is not the last time you're going to be on the podcast. So thank you so much for being my friend and also our resident SLP expert on hand.
Well, thanks so much for having me.